Welcome everybody, welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual, and today I want to talk about something I do and use all the time in the Pediatric Emergency Department, sedation. Conscious sedation, specifically with ketamine. So it's very often that we do painful procedures in the Pediatric Emergency Department, and for painful procedures, ketamine is just a great drug. As far as I know, it's the only drug that is a sedative, amnestic, and analgesic. So when you use it, the patient is sleeping, not having pain, and doesn't really remember a whole lot when he or she wakes up, which is great for pediatrics. I can't think of a situation where I would sedate a child in the Pediatric Emergency Department for something that is not painful. Certainly, if you're sedating a child for a non-painful procedure, you can use something like propofol, which is not an analgesic and fairly safe. However, in the Pediatric Emergency Department, when I sedate someone, it's almost always for a painful procedure, and ketamine is my go-to drug. I do want to spend a few seconds talking about when do I use ketamine. I think it's important for us pediatric emergency providers to understand and relate to the parents that sedation is a fairly serious procedure. Although it's safe majority of the time, and majority of the time there are no significant outcomes, there is a reason we have to obtain consent. We have to obtain consent because it is a procedure that involves risks. So for the most part, sedation is something that I try to avoid when I can. Remember, for lacerations, we have LET, lidocaine, epinephrine, tetracaine gel, which does a great job in taking away the pain. You can always give benzodiazepines such as Versed for anxiolysis. So I always try to avoid sedation if I can. Certainly, that's where child life comes into mind and comes into action. They are very helpful in distractions. And most of the time, I must say, I'm fairly successful performing most of my procedures with just that and avoiding conscious sedation, which again is for the most part safe, but does involve risk, does require consent, etc. So it's something I try to avoid when possible, simply because I don't want to put the child at risk for what is unnecessary. Having said all that, I would say that ketamine is fairly safe. It has some side effects which we will discuss, but kids tolerate it very, very well. So again, the drug of choice because it's a sedative, analgesic, and amnestic. What I teach the residents and my medical students about ketamine is the following. So very few things in medicine are 100%. However, 100% of kids with ketamine get hypertension. Usually normal, healthy hearts, young hearts, I do nothing for it. It's a transient hypertension, it goes away. It's not something that is clinically very relevant or significant, but it's something I make sure my trainees are aware. Ketamine is notorious for the possibility of causing laryngospasms, which is probably one of the worst side effects you can have. Laryngospasms basically will sound like the patient is all of a sudden having croupy cough or upper airway obstruction with stridor. Not something you want to have, and something you can avoid by injecting ketamine slowly. So when I give ketamine, I inject it slowly. If after injecting it, your patient develops stridor, yes, you have probably laryngospasm, and the first order of business is just to do a jaw thrust. May or may not help. Your next go-to is to ventilate the child and overcome that obstruction with the bag and mask, which is why when you sedate a child, you want to have SOAP, suction, oxygen, airway, and pharmacy. We talked about that in a previous podcast. If after ventilating the child with the bag and mask, you still have significant stridor with maybe hypoxia and difficulty breathing, unfortunately, one must entertain the possibility of paralyzing the child, unfortunately, to stop the laryngospasms. I've never had to deal with that situation, but it's something that is always on my mind. Inject ketamine slowly to avoid laryngospasm. As with any medication, kids can get allergic reaction to ketamine, something that I don't particularly worry about. I can treat allergic reaction anytime. But those are the major points that I think about when I use ketamine. Hypertension, which again, clinically insignificant, and laryngospasm, which I avoid by injecting it slowly and making sure I have all the equipment ready in the room in order to overcome them. I usually use ketamine at a dose of 1 milligrams to 2 milligrams per kilogram. I must say, from my experience, especially toddlers, they almost always require 2 milligrams per kilogram in order to achieve good sedation, and I always make sure I have the full dose before I start my procedure. Once I inject ketamine and the child is asleep, I pay attention to several important things. Number one, you want to make sure the patient is not becoming cyanotic or pale. Remember, monitor the patient, not the monitor. The other thing you want to make sure is that the pulse ox is remaining normal. So the pulse ox should be, as usual, above 95% or 92%. You want to make sure the child does not become hypoxic. Now, in my hospital, I have the privilege of having a respiratory therapist in every sedation with a CO2 monitor, which is great. CO2 monitor lets you monitor the real risk with sedation, which is apnea, which will cause the child to accumulate CO2 with or without becoming hypoxic. I always remind my trainees that the child can potentially stop breathing, have normal oxygenation for a few minutes, however, he or she will accumulate CO2, which is not a great thing. Having a CO2 monitor allows you to monitor the CO2 level and make sure the child is not becoming hypercapnic. The CO2 monitor needs to range between 35 and 45, and the challenge is what to do if you don't have a CO2 monitor. I don't believe having a respiratory therapist and a CO2 monitor is a standard of care in every hospital, and I teach my trainees that if you don't have a CO2 monitor, the way to monitor the CO2 is by looking at the respirations. So you want to make sure you see a chest rise. When your child is sedated, if you're seeing chest rise and no hypoxia, likely the CO2 and the oxygenations are within normal limits. During the procedure, depending on the dose that you gave, the child may be completely quiet and completely sedated. Some kids tolerate the sedation a little better than others, but I think keeping it at a dose of 2 milligrams per kilogram is almost always safe. As with any medication, specifically sedation and pain medication, I try to start with the low dose and always give more if I need to. So I usually give 1 mg per kg, start the procedure, and depending on the level of sedation, I give more. Again, this is really simply for the patient to wake up from the sedation as soon as possible. Usually my procedures are fairly short and I don't want the child in the pediatric emergency department staying any longer than necessary. Now, once the procedure is over, unfortunately, some kids after the procedure, when they wake up, seem to have what we call emergence phenomenon. The way I would describe it, unfortunately, the child is having delusions, as if he or she all of a sudden became schizophrenic. It is a very scary experience for the parents, quite shocking to the provider as well, depending on their level of comfort and experience. To my understanding, the best way to treat that is to turn off the lights, try to reduce the stimulation, and just let the child be. I have in the past personally given Versed to some kids that had a very serious emergence phenomenon. Certainly something that is available for you and you can do very safely, giving some Versed, some Ativan, or whatever benzodiazepine of your choice. Usually, I personally send the child home after he or she are more awake, tolerated something by mouth, so I make sure they're not vomiting, etc., and then they're good to go home. Now, what I'd like to do in the next minute or two is tell you how I talk to parents about ketamine in terms of obtaining consent. So when I approach the parents and talk to them about consent for sedation, I tell them the following. So most commonly, I use ketamine for fracture reduction. Either I reduce the fracture myself or the orthopedic is there to help me. However, as the pediatric emergency department, I am responsible for the sedation all the time with or without the reduction as well. So here is my little speech to the parents. So mom and dad, we're going to put your child to sleep in order to get this procedure done. What we're going to do right now is called conscious sedation. The way I think of sedation, if you think of anesthesia, anesthesia is something you have when you go to the operating room, and anesthesia is a very deep sleep where everything is done for you by machines. You can breathe on your own, etc. Sedation is basically a step below that. You're asleep, you don't feel pain, but for the most part, you breathe on your own and I don't have to do a whole lot for you. I am ready for the worst. However, it is very rare that I actually have to intervene. Unfortunately, mom and dad, there are some risks associated with conscious sedation, and I'd like to discuss those with you in order to obtain your consent. So, number one, it is very likely that your child will experience high blood pressure during the sedation. The medication I'm going to give him or her is called ketamine, and unfortunately, ketamine is notorious for causing high blood pressure. Since your child is healthy and young with a healthy young heart, it is transient. I don't do anything for it, and it kind of just goes away. There is always a chance with sedation that the child's oxygen level may drop. I am ready for the worst. That is why I'm going to have oxygen in the room the whole time. I'm going to have a respiratory therapist in the room the whole time, and I would monitor your child's oxygen. If I need to, I can give your child oxygen. I can even breathe for them. It's not something I ever had to do, and it's not something that happens very often at all. However, I am ready for it. I also want to make sure you know that ketamine, like any other drug, since your child has never gotten it before, can cause an allergic reaction. I always tell parents there's no better place to get allergic reaction than the pediatric emergency department. I can treat the worst allergic reactions ever. When your child wakes up, he or she may experience some delusions, which are not very common, but unfortunately do happen. If that's the case, I can give your child a medication to help him or her relax, and usually those are transient and go away with time. Another thing that may happen with sedation is when the child wakes up, sometimes, unfortunately, they have some vomiting, which I can treat with a medication called Zofran. By all means, we will make sure your child is able to drink or eat before he or she go home. Make sure they're not vomiting prior to discharge. And that's pretty much it. Overall, we use ketamine in our pediatric emergency department almost daily, and it's a very safe medication. At this point, I have the parents sign the consent and I make sure they have no other questions. This is basically my translation of the risks of benefit with ketamine to the parents. So if you're not familiar with ketamine sedation, I highly recommend you learn more about the drug and the uses of it. It really is a wonderful medication that helps your patient tolerate the procedure and helps you do a better job. It's always easier to suture a child that is not moving, not crying, etc. And that is it for today, guys. I hope you enjoyed the episode. I hope you continue listening to PEM Rules and email me with any questions or concerns. The outro for today is one of my favorite songs by the Red Hot Chili Peppers. Those of you who listen to the show may recognize it from the outro for episode 12. However, as much as I love the bass guitar, I have to admit it sounds so much better with the electric guitar in the background. That's the best I can do. Hope you like it.